I'm Rob.
And I'm Mike.
And welcome to another edition of Let's Get Ethical.
All right. I swear to God, one of these days I'm going to get it all right.
Well,
I swear. Good. Yeah. So how you doing, Rob? What's going on, dude?
I'm
how
good.
You been?
How are you? So today, officially, I'm post-op day 7. A week ago today, I had surgery on my right foot. It's doing very well, doing the crutches, doing the boot thing. I finally got out of the house today, first time in 7 days. Shout out to my youngest daughter, Ella, who came and picked me up, and we went to Starbucks and got some coffee and drove around a little bit and talked, and I got some fresh air. So that made my day excellent.
Good. Nice. I've been hiding in the house today. It's
oh man. Yeah. No,
it's 100 degrees here. So
yeah. Better you than me.
Oh my God. Yeah. But California, what are you going to do?
I know. What are you going to do? California. Yeah. Well, here we are. Another episode. We have an exciting guest today, don't we?
We sure do. So, we had a conversation with this gentleman on LinkedIn, actually, and he posed an amazing question that we wanted to bring him on and kind of get to. We'll get to the question in just a second. His name is Dr. William Croft. Bill has spent more than 37 years in respiratory care. 22 of those have been in academia as a professor and program director. Since 2014, he's served as the executive director of the North Carolina Respiratory Care Board, where he's been a driving force behind the profession, both at state and national levels. He served on the AARC APRT committee, so I'm since 2018, and I'm expecting he knows Mindy. So I'm curious to ask him. And he was appointed co-chair in 2022. So he's successfully lobbied for landmark APRT legislation in North Carolina. So let's go ahead and bring him on. And everybody help us welcome Dr. Bill Croft. Bill, how are you today, sir?
Bill.
I'm doing well. And you?
Welcome to Let's Get Ethical.
Now, I'll answer your first question. Yes, I know Mindy.
Yeah, reading your bio, I'm like, oh my gosh.
Yeah, who doesn't know Mindy at this point? Everybody knows Mindy.
So I told her, I think it was one of the meetings, either Congress or wherever. I told her, if I could have built a perfect APRT that would go out and promote the profession, it would be her. And she's awesome.
Yes.
Awesome. Yeah, we just had her on our last podcast. Yep. And we've kind of known her through RT Sidebar, right? Because we've been on that, and we kind of partner with RT Sidebar quite a bit, and so we've known her a little bit through there. Finally, got to meet her at the California Society for Respiratory Care conference in April, and we were able to bring her on our podcast at the conference. So that was actually really cool. So got to know Mindy quite a bit. We're actually bringing her back on for our next podcast because we just had something pop up, and she reached out to Rob, I think it was, right?
Yes. Yeah.
And so we're excited. But when I saw that in your bio, I was like, oh, that's awesome, because we're pushing for that in California. Yes. And you've had how many? Is it 2 or 3 now pieces of legislation that have moved through?
Well, I've introduced 5. We've had two to pass the House. Right. But we're stuck in the Senate, and we're still trying to get out of it. There's some forces out there that are playing against us politically, and I'm fully aware of that. The good news is we cleared the way from the medical board side and the nursing anesthetist side to kind of not oppose us, and that way we can work on the real politics of dealing with the legislators on a daily basis, which I'm going to be doing tomorrow.
Wow.
Fun
so
time.
Before we came on right now, you mentioned that you had a busy day. So I'm curious about your job.
Okay.
I'm curious about being the executive director for a respiratory care board. I'm not involved in our respiratory care board. Never have been. Rob has. I'm curious, what does that entail? What does executive director entail? Just real quick. I know we're here for other things, but I'm just super curious.
Well, one of our primary functions is to issue licenses. So reviewing backgrounds, that kind of thing. That would be something I would do on a daily basis. Right now, it's particularly busy because of graduation, part of that job is also looking at, like I said, the backgrounds and looking at what the criminal backgrounds of therapists, because we do, like any society, you're going to have people who've committed a crime here or there, and I think we're going to talk a little bit more about that in a little bit. But
yes.
Which is why I'm here. The
Absolutely.
other side of my job is I'm liaison to the North Carolina General Assembly. So basically, I'm a lobbyist also. So I serve as the lobbying individual that goes to the legislature. It's mandated by statute that I do that. And then also I'm a rules coordinator, so I write rules and get those passed through the Rules Commission. That one's a little bit more straightforward, and it's also one of those jobs that takes a lot of tedious work of working through legal language to get a rule that'll pass the Rules Commission. I've got 12 or 13 rules right now that are in process, and it's going to help us, soften some things up and make things a little bit easier for us to function, assuming we get everything passed that we'd like. And it's been a real challenge because ever since COVID, we've been wanting to make these changes, but we haven't been able to because we just had so much going on. During COVID, it was just an insane. Well, we all know it was insane, but from the licensing perspective, that made it a real challenge because we had to figure out a way to more rapidly issue licenses and avoid the obstacles. And so we had to kick into high gear. And a lot of the things that we did during COVID, we have continued, and that's one of the things that we're doing right now is codifying in rules.
Gotcha.
And
some of the temporary provisions you're deciding whether or not we need to keep, and you gotcha.
Right. And also, the other part of my job is to do investigations, put investigatory booklets together for the committee and the board, and present cases. It's kind of like our attorney said. He said, "I'm probably now in my 5th or 6th year of law school." Because I've had to do so much, with the legal language, but I really enjoy that because I find some soft spots that we can, do things that we wouldn't normally think we could do, and sometimes it's better if the statute isn't clear, because that gives us the opportunity and rules to make those changes, which is kind of what we're doing now.
Gotcha. That's kind of awesome.
That's really awesome.
Yeah. The reason we wanted to have you on, and I know you know this, but so that everybody else hears it, we had a post, and we were our post. I can't remember the exact post, to be quite honest, but we were talking about. I mean, the podcast is on ethics, and we were talking about ethical behavior. And on one of our podcasts, we had mentioned that only 11 states require ethics as part of licensure for respiratory therapists. And you commented with a question. And after that, we were like, we need to have you on. And your question was literally, do mandatory ethics courses improve ethical conduct of licensees? And I thought that was such a good question, because and I've reached out recently to our respiratory care board, because California was, I believe, the first state to require ethics for licensure. And so I helped I co-authored our most recent one that just went live in January 2026. And since starting this podcast and now presenting that one time live at the conference, it occurs to me that the approach appears inaccurate, incorrect. And because it's very lecture oriented, it's just throwing information at you. And so this question to me is actually your question is more important, I think, than ever. So I'm curious, wherever you'd like to go, but I'll start with your thoughts. What are your thoughts with regards to that question? I mean, you asked the question, I'm sure, because you have your answer, or at least your thoughts on the matter. Let's get to those to start.
Well, I was telling you, about the one of the papers that I did while I was in grad school, and it was an ethics course. And I focused my last doctorate on education leadership, but it was a focus in psychology because I could choose to go do clinicals and be a psychologist now if I wanted to.
Okay.
But when I took that course, it really started me thinking about, wow, we have such a dearth of information out there that's not really being brought into these curriculums, and certainly not tested on. So it prompted me. I had to do a lot of writing, obviously, in that course. But so I took the actual ethics guidelines for the APA, which is something like, I don't know, don't quote me. I think it's like 50 pages.
A lot of pages.
A lot of pages.
A lot of pages.
And it just, I was enthralled. Now, for most people to go, why would you want to read something that boring? It was for me, and I know Rob would probably appreciate this. The fact that there was so much depth to it, and I'm thinking, all right, so with all of that depth, and I started looking at psychologists and all the issues at the psychology board. I get a it's a journal basically. It's on all of the licensing agencies participate in. Well, not all of them, but I like to participate in it because it's like a journal for all the cases that are out there. And you start reading some of these things, and I'm thinking to myself, the APA guidelines are very stringent by comparison to ours. I mean, hands down. But yet, you read about cases about people breaching that ethical barrier constantly, and not just in that field, but almost every field that has a strong ethics built into their curriculum or built into their sort of drive home. But I was just enthralled with the psychology part because I was in the psychology division, and I really started thinking, wow, this it's great that they have it, but is it working?
Mm.
And then I looked at ours and went, my gosh, we're just sort of on the surface of the material, and we're certainly not delivering it if I'm not criticizing the code of ethics, trust me, because a code of ethics is what it is, but there needs to be more meat behind that code of ethics. And one of the things you'll find when you read the APA ethics guidelines is they give you case studies. I say, case reviews of, present a case and, what do you think about this? What, should that person have engaged in a relationship with their patient? Well, obviously the question answers no with that, but, they give you food for thought. And so I started structuring a lot of, like, when I would be asked to come and talk about things like this around the state, I would just base them on case studies and, just of what we've seen. And I do this when I go visit the schools. I go and visit the schools and tell them about licensing, but that's just sort of a ruse to get me in the door because what I really want to talk to them about is how to stay ethical.
Right.
And I sort of randomly, from my memory, pick scenarios. And I'll tell them, I say, look, we're going to review our rules today. I said, and you're going to be tested on it. So I'm just going to give you a few things to think about first. And we start talking about cases. And, obviously for us, it's going to be pretty simple. Someone shows up to work, first on first shift, and someone notices that they're not acting, like they should. So they tell their manager, and the manager, has them for cause testing. And the person tests for, tested blood alcohol level of 0.365.
That's high.
So imagine these are second year students, right? Yeah. What do you think? Do you think that's a violation of the Practice Act? Of course. I mean, that's an easy one. Right?
Yeah, everybody answers that yes.
Yeah. I mean, it's like, of course.
That's an easy one. Yeah.
Right. Well, then I give them a juxtapose that to another one, which was, okay, I have another practitioner who shows up on day 2 that's stumbling. And again, one of the other staff members picks up on this and reports to the manager. The manager does a for-cause testing. The person reports to the manager that they are on prescription medications, and here are all their prescriptions. Okay. Well, they test positive, obviously, and for all the medications that they said they were testing for. So the problem is that the test showed that the medication was about 4 times the therapeutic level for all the drugs taken.
Wow. Yeah.
So I'll pose this question to the students. Was that a violation of the Practice Act?
What do they say?
Well, I get mixed reviews. I hear some of them will say, well, it's a prescription drug. I said, true. And the other one will say, but they're taking too much. That's true.
Mm-hmm.
And it's not as easy to answer that question because you have to know things like, I mean, for example, were they taking 4 times as much, or did they have liver dysfunction and their body was, building up a quantity of that in their system? That's a possibility. So it's hard to say, was that an ethical and breach in that case, because it puts patients in danger, obviously is, but is the cause-effect relationship what we think it is? Were they taking too much? Were they abusing it? Were they doctor shopping? And that's what led to this? Or did they have liver dysfunction? I mean, anybody I think this person was on like 5 different medications. It's going to affect the liver. And, if they were also a drinker, which we don't know that they were because they didn't test positive for that. But if they were also a drinker, they could also have some liver dysfunction, which can inhibit the, breakdown of that medication. So what it does is sometimes I present them with an obvious case, and then I present them with a murky case. And that's the ones that I love to discuss because it's not always easy. And that's the purpose of an investigation, is to look at the mitigating circumstances for each of those situations. And but those are 2 examples, and in both cases, unfortunately, those individuals, while they were put on a consent order, they just one of them never got a job again, and the other one had to drop the license altogether because they couldn't complete the consent order. But in both of those cases, we put them into a program, what's called alternative program, where we try to get them help, and we put restrictions on certain things that they have to do with employers' supervision and counselor supervision, drug testing, and it can go on up to 5 years. So it's a very rigorous type program.
Yeah.
But in those cases, to me, that's the right way to go about trying to help someone save their career if they're willing to do that. Sometimes they are, sometimes they're not, and it's unfortunate.
So go ahead, Rob. Go ahead, Rob. Go ahead.
You brought up some really, really good points that I kind of want to go back to the original question, right? So do mandatory ethics courses actually improve ethical conduct of licensees? And you gave some good examples of what you present to students. And I wonder if you think in your experience, and Mike, you too, in your experience, when you as educators educate, for example, a respiratory therapist on bioethics, how much time do you spend teaching bioethics? Are you sticking to just those 4 pillars? And do you believe that the way in which we're educating healthcare workers, and we'll just say RTs or healthcare workers, on ethics is likely being done differently all over the country? Do you think there's consistency in the education of biomedical ethics to students? What are your thoughts?
My thought would be, the answer would be no to that, because I mean, when I talk to people, and when we had an investigation, it's obvious to me that they're having a hard time. And I gave you some extreme examples a few minutes ago, but there are examples of decision making that involve ethics, that involve patients, that people are engaged in, and they're having a hard time seeing, what the problem is. Everybody else does it, so therefore it must be right. And it's a good example of that. And it most commonly comes down to simple things like the charting issues. Sometimes it's I will just say, for all intents and purposes, they're trying to make it as easy on themselves as possible. But I've got to give you an example for this because I have a hard time just. All right, so
go ahead.
We had a practitioner who, and not just one. We've had multiple. That's why I'm saying I don't. And these are people from all over the country and within our state. and they would chart, but they wouldn't chart until they would go back to the department, right?
Yeah.
Because I understand that, especially during COVID, and fine, but some of them weren't actually going to the rooms, but they were charting that they did. So we would ask them, what was going on there? Why did you chart? Well, I was putting information in the chart before I went down there and it all had to do with COVID, right? They were all sort of geared around that. And I said, but you were charting things that you hadn't done yet. We call that pre-charting. I said, do you think that is acceptable? And almost always they would say, well, it's not ideal, but we have to do it, and everybody else does it, right? That's sort of their go-to answer.
Right.
Yep. Yeah. Everybody falls on well, Jane and Jack did it, so it's okay for me to do it.
Right.
Yeah.
But I think the most egregious ones to me were, when they would, so let's say they did go in and they did do the treatments, and then they waited to the department to go chart, right? So we're talking, I don't know how many hours. And what was interesting is that they were reported for falsification of their documentation. And they were claiming that, no, they documented. But then when you compared the notes to what they actually wrote, I say the notes, everything else was going on with the patient. So compared to what they were writing, something was off. And I found out just through questioning that they were just, I would say, making it up, because they had not written a thing down, waited at least 4 hours before they charted. And then they would walk in to the department to do their charts. And I said, well, how do you remember the time because this is how they got caught. The times were 1 minute apart.
Right.
And so, how did you know what the breath sounds were, the heart rate, the respirations, the changes after the treatment? I certainly you could figure out the medication because that's on the computer, but how do you remember all of those? And I said, you've had 10 patients. I said, well, I have a good memory. And I'm like, no.
Wish my memory was that good.
Yeah, seriously.
I would never rely on that. I mean, we've actually had to coach people on how to take notes, in an investigation, because they were either never taught, but they were also not taught that it was wrong to do what they were doing. At least that's what they told us. Now, I don't believe that completely. I think in some cases what has happened is they've gotten into bad habits. They've watched other people do it. And I have no doubt that, some of the other therapists were probably getting away with it. They just happened to get caught.
Yeah, right, that seems weird to me that anybody would think that it's acceptable to chart anything prior to going to the room, right, simply because even if I charted it right now, got up and headed straight to that room, I could be sidetracked by a code and never get to that treatment. Now that documentation is that's done. Yep. Yeah. Yep. And so that just from a common sense standpoint doesn't make any sense to me.
And that happened on a number of occasions. And we get a lot of these cases. It's not just a few cases. Sometimes it makes up the entire investigative quarter. We get these types of situations, but they all come down to, I'm pushed for time. I've got to get these things done. We'll get written up if we don't get this done or that done or whatever. And it's causing an ethical breach. Mm-hmm. In other words, obviously integrity is high on our scale of things that we have to have integrity in everything that we do, because if we don't, then we're not serving the patients. Right. The patients aren't getting what they deserve. Right. And so that's our main focus. And I mean, I actually had to, and some of it has to do with technology. Technology makes it a little easier to do some of these things. You remember back in the day when we had just paper charts. I mean, I carried around a notebook with me, and I had my everything I needed, and I would write everything down, and I would take it to the chart, and I would write everything down. Now with the technology, I think it makes it a little easy, and I think it's part of the ethics training of how to properly use technology in a way that actually makes your life a little easier, but without breaching ethical violations. Mm-hmm. One common thing that we would see is cut and paste.
Oh yeah,
all the time.
All the time.
Or the Meditech system with the recall button.
Right. And that's a question I always pose to the students. I said, okay, well, you've got a cut and paste feature on your computer for the charting. And would you do it? And some of them would say, well, yeah, we do that. I said,
I have to tell you really quick. I got to tell you a story, just a real fast story, totally with regards to the cut and paste, or in my case, it was the recall button. When I worked in a hospital where I was one of maybe 3 people in the respiratory department who carried a stethoscope. Yet I would come on shift, I would take report, and I would go to chart. And if I looked back, I would find that the patient had the same pre and post heart rate, same pre and post respiratory rate, same pre and post breath sounds for the last 12 hours.
Mm-hmm.
Yeah.
And
never changed.
Yeah. I just had to bring that up because that's horrible. And I couldn't, even if my patient's heart rate was 88, because they posted 88 for 12 hours, I felt like I need to take it again till it's 86. You know I mean?
It's got to be, it can't possibly be 88 for 12
put
hours.
The same thing they put. My God, it was that kind of a response.
And we saw that with the ventilator flow sheets even before they were computerized. People would just document. They're okay, just write everything down. I caught that so many times when I was still practicing. It annoyed me because it was like, you're not looking at your patient if you're doing that. So I found one case where we laugh at this. It's not funny because it could cause real harm. This was back in the day when we had inverse ratio ventilation. Okay, but the patient had not been ordered to have inverse ratio ventilation. But for the last 3 days, or it was over the weekend, so Friday, Saturday, and Sunday. I came in on Monday. They had been charting inverse ratio ventilation or inverse ratio. So I'm looking back and I'm like, that shouldn't be the case.
And when you came in, the patient wasn't on PCIRV.
Oh, no. Well, this is before we even had that. I mean, we had to do that, manually, with the flow rates and all that stuff. And, we didn't have a mode. we had to actually create that.
Pushing the flow up to the I time. Inverses.
Right. Exactly. So we were doing that. And so I caught this and I went, wait a minute, that can't be right. And so, but I always made it a habit of just to chart what I did first, and then I would look back rather than the other way around, because there is a tendency, I think, probably to take a shortcut because it's like no one's looking, they're going, who's going to know? Well, I can tell you today, I can catch people so much easier even though we're not even near the room, because we get the readouts from the ventilator. When we're doing an investigation, and we can go back in time and follow everything.
Absolutely.
And a good example is we had one facility that we were given a very lengthy complaint on, and there were probably 10 people that were in the complaint. And this one practitioner had enough, and she actually did the old fax, so I had to retype everything. Nice. She didn't send it by email. It turned out that everybody in that facility, it was a long-term care facility, was on 60/10 for their high pressure, low pressure.
Yep.
And
that's not an uncommon practice, is it? It's not an uncommon practice.
Check it. Yep.
Right. Well, so to make matters worse, we brought the entire supervisory staff in because to make matters worse, what had happened was because the manager recognized there was a problem. So she started having the human resource manager who came in early in the morning to go around and check to make sure what the patients were on. Human resource manager, not a cleanician.
That's odd.
Well, that's what set off the investigation. We took our investigatory team to the facility.
They were looking for it, right? Yeah.
Yeah, and so this had been going on for months apparently. And when we looked through all the charts because we were given specific information. We looked through all the charts, and there was no reason for anybody to even be anywhere near high pressure of 60 because most of them were sitting between 22 and 30 at the most. Mm-hmm. So we went chart by chart by chart, and every time we would see, and we asked, well, why are you doing this? Well, that's what the supervisors, they say it's okay. We don't have alarms going off. And
what does he say?
It's not only unethical, it violates our clinical practice completely. 100%. I mean, it was so egregious. But again, that was an extreme situation, but it was bad enough that the board sent our entire team to that city. We rented a hotel room and a conference room, and we brought everybody in because we were like, this is dangerous.
Yeah.
Yeah, it is.
So let me ask a question. Was this before the days of mandatory ethics education?
Well, we've never had mandatory ethics education here.
So North Carolina is a state of those that we talked about that doesn't have mandatory education.
Right.
So I think the answer, I think one of the answers here is, Mike, and you can agree or disagree, but do mandatory ethics courses really improve the ethical conduct of licensees? I mean, I don't know that you can point a finger and say that it does, right? I think if we know that as we were talking about kind of in the beginning, right? Ethics is philosophical.
Right.
It's wider than the Grand Canyon. It's farther than from here to the moon, and its depth and its breadth. And when we think about ethics education, we think about we're combining ethics and law and professionalism, and our goal is we want to help students to be and licensed professionals to be better ethical decision makers. Right? We want them to have better behavior and strong professional identities. Each one of us already comes to the table with a set of morals and values that we learn from our parents, right? We come to the table with an ethical mandate. We should understand what professionalism is. If you said to those same people, go ahead and go down to the corner store. I want you to go in and I want you to steal a Coke. What do you think they'd say to you? Either one, Mike or Bill, what do you think they'd say to you?
Well, they'd say that was not, that's illegal.
Right.
They'd
say that's unethical. I can't do that.
And
well, the interesting thing is what the required ethics courses do is, and I agree with you, Rob, that they don't necessarily make us more ethical. They allow us to be more accountable, right? So they give us a degree of accountability because I know in California they can look at it and they can say you're required to do this. You've documented that you have done it, so you've done it. Therefore, I can hold you to this, right? It raises that standard just a little bit. But the question is, if we're going to be teaching it, if we're going to be requiring these, isn't there a way that we can, at the very least, I mean, maybe it's not, because like you said, Rob, everybody has their own set of morals, their own set of values, their own things, right? But isn't there a way that we can, at the very least, raise awareness individually with regards to ethical decision-making and ethical processes and what, just as a reminder, isn't there a way we can do that? I don't feel that lecturing necessarily does that.
So I think the way that we're going about it, and Bill, please jump in if you feel the same. The way that we're going about it is likely not the right way to go about it.
Right.
I was doing a little bit of research, Bill and Mike, before we came on today, and I was kind of reading an article that came out about 6 or 7 years ago, and I was actually in Harvard Law, and it talks about ethics specifically in healthcare. And again, one of the author says if there's 140 medical schools, and there is about 140 medical schools in the United States, guarantee you each one of them is teaching ethics differently.
Right.
And it would be easier to teach ethics if we didn't come to the table as humans already having a predetermined set of morals and values and ethical decision making, because everybody would be on the same plane when you're teaching it. And what you and myself and Mike, we've all kind of figured out that, yes, we can talk about the 4 pillars of bioethics. And it's important that we talk about those things. And even Mike and I go into veracity and formalism and intuitionism and virtue ethics, because that's important too. But what we have found, and I think also what again, reading in the literature, what the literature really supports in getting healthcare workers to better understand ethics is using case studies.
Yep. I agree with that 100%.
Is using case studies.
Because I do, when I go to and talk to students, or I'm even doing a presentation at a state conference, I'm using case studies, and people are more engaged. And that's the key, is that it doesn't matter what topic we're talking about, whether it's ethics or mechanical ventilation, you've got to engage the audience. And I've go to so many conferences that we're talked to, not we're having a discussion right now. That's what people crave. And I think most of the time, if you can get them to talk, you're going to find that they're going to get a whole lot more out of it. And
absolutely,
amen to you. Yes,
yeah,
yes.
So it drives me insane when I go to a conference and I'm sitting in a lecture, and I feel like it's like, after a while, it's like they're showing all these charts and graphs and everything. I'm like, I just want to ask a question. Can I raise my hand and ask a question? Because I have an interest in it, but all of this other stuff that you're showing me is not as interesting. I'm the bottom line type of person. I want to know what's the bottom line of the study so I can go backwards.
Absolutely.
And, just because, I've got a curiosity of, like, I don't want to wait to the end. I want to know now. And then I want to go back.
What did you find, so we can figure out how you found it, right?
Right. Exactly. Exactly.
Yeah.
And I find it more interesting. It's like reading the last the last chapter of a book and then going back. I don't do that, but I mean, there's some things that, you just want to get down to the brass tacks and say, hey, here's the bottom line. Okay, let's talk about how we got there. And, but you're right. I mean, you've got to bring people into the fold, and they've got to want to come. So that's sort of the challenge. So one of the things I mentioned to you when we were speaking before was that we will always build in an ethics portion for anybody that we have a case that we have to adjudicate against if it's an ethical violation. And we have them take specifically the AARC ethics course. That's the best we can do. And we have one individual who did that several times. And ended up having their license revoked eventually because they couldn't get themselves straightened out. And I was like, this is just not effective to just take the course. There's got to be engagement. Someone's got to pull them aside and say, this behavior's not right. Here's why. Not just this is behavior's inappropriate. And that's the thing. Sometimes people are justified, they feel justified in their behavior because, I don't know, maybe somebody did them wrong, and they just somehow figure out a way to justify it. And it always blows my mind. It's like, how do you just leave your morals and ethics and virtues and values aside because somebody treated you badly? To me, it would be the opposite. You go above and beyond to make things better. And
I think a lot of that gets chalked up to and this is I guess a dangerous statement, but whatever, I'll say it anyway. Insecurity. When we're insecure, we hate to be wrong.
Oh, 100%. 100%.
When we're more secure about who we are and where we want to be and what we want to do and what we want to accomplish, we're more willing to be wrong. It's an insecurity. Maybe it's more fear, right? Maybe it's something along those lines where I'm afraid that I'm screwing up, so I don't want to admit that I screwed up because, God, I really don't want that to be the case. Yeah, I don't know,
Well,
that speaks to integrity, right? But I do think there's a monkey see, monkey do attitude sometimes. And I don't understand. I think sometimes the people don't realize that we know the minute you logged into the EHR, we know the minute you logged out of the EHR, we know the minute you went into the patient's chart. Any keystroke is timestamped in the electronic health record. So, like, when you give an example of, well, I've already charted in the department, now I'm going to go see the patient. Mike, you made a good point. Well, what if you got called to a code 5 seconds after you got called out the door, but you never saw that patient, but you're going to say, well, no, I did. Here's my charting. I don't know if people don't realize it's not that difficult for investigators to peel that onion back and say, you didn't. And why didn't you? And again, to your point, Mike, people stand on this conviction of, well, I documented it, so I did it.
Right. And even if you could, or even if I'm going to say that it's going to come out wrong again, like everything I say. Even if they wanted to be honest and say, oh man, I got called to a code, I didn't do that, I need to delete that. we can't delete that entry. And even if they could delete the entry, there's still a timestamp that they entered something and then deleted it that is now a permanent. And so there's all these ramifications that should something happen, you know, and from a litigation standpoint, the question's going to get raised. Why did you do that? Regardless of what you did, why did you enter something, then delete it? What happened there? Why didn't you leave? What was wrong? You know, and all of that creates, it just opens this can of worms for litigation, and ethics itself opens, you know, or unethical behavior opens that can of worms, because the tiniest corner can have the largest consequence.
Correct.
Right. Well, and think about this. You know, we described a situation where people know effectively that Big Brother's watching, literally, but yet they choose to do the wrong thing. To me, that says more about an individual who just has a lapse in at a weak moment. But
that's
they know,
character thing.
Yeah, those are the ones that really concern me, because they're making that choice even though they know people are watching. And then they're trying to justify why they did it, which it doesn't hold water at all. You know, you can't say, oh, I mean, just so, you know, we have long conversations sometimes with practitioners, and we find out that they really never had that much ethical training. And even though they see that it's wrong because they see other people, and that's the thing, you know, you see other people do it, you think, oh, it must be right. You know, if other people more experienced than I am can do that. But, you know, I guess for me, it's always been, if you start with the patient first and you think about what you're doing, and are you doing that patient justice? And if whatever your action is not doing that patient justice, you're violating you're ethically breaching clinical practice, because you're not doing what's best for the patient. If you start with, I've got to get my job done as quickly as possible, you're going to find shortcuts. Those shortcuts may start out simple, but then they build up and they become a real monster. I'll give you a really shocking example of a patient that was transported on a ventilator across the hospital in standby mode because they failed to flip the switch, but swore to us that they did. But when they showed us, when that individual showed us the screenshot of the ventilator screen, big letters, standby.
Standby, yeah.
Wow.
And
that's why they're in big letters too.
Now, I'll be honest with you. In this case, it was, you know, I guess it wasn't that he did that intentionally, obviously, at all. He made a mistake, and now he's trying to cover it up.
Yeah,
just and then and you know, we felt bad because he had an unblemished record, you know. But we said, look, I said, you know, you're telling us that you did that, but it's clear as day that it was in standby. And we went through all of the documentation from the manufacturer that because we had to consult the manufacturer on this one. This particular ventilator only would show, I think, going out of standby, but not going into standby is weird. And but it was the screenshot that sort of did it. It was like, well, that's obvious that they were in standby. But unfortunately, the patient died. Yeah. And it wasn't the first time it happened. It was the second time it happened, not with this individual, but another individual. It all came down to rushing during the day, trying to get things done. A patient comes back from, you know, OR, put him on the ventilator, gets to take him out of standby. How do you do that? Well, you do that by first looking at the patient, before you put the patient on. When you put the patient on, look at the patient again. And we went through those things, and they were like, well, I didn't have that much time. I'm like, you have all the time in the world when it comes to patient safety.
That's right.
But
and it takes less time to do it than it did for you to just say it.
Yep.
Right, exactly.
Yeah.
100%.
Yeah. Exactly. Yes.
But I mean, I think I told you I counted again. We have probably seen over 1,000 cases over the years. And it's just, you know, when I look through some of them, I'm just like, how did that even happen? Well, a lot of it happened because people use bad judgment. And a lot of times it was intentional. Like I said, they knew what they were doing was wrong, or they thought it was wrong. I even presented to one practitioner because she was young, and she was, you know, maybe 2 years in, and you could tell she was under a lot of stress, and she couldn't get to all of her treatments. So what she was doing was she was charting that she did the treatment, and obviously she wasn't. But like you said, how do we know she didn't do the treatment? Well, it wasn't charted, but also the video camera showed that she never went in the room.
Right.
So, I said, well, we, after a long discussion, we figured out that, she was never really trained on how to manage her time. I said, you know what? I said, when I was a practitioner, I would write myself up on a daily basis. And they all looked at me like, huh? I said, yeah. I said, if I missed a treatment or had to miss treatments because I was in a code, I have missed the treatments. So I wrote up that I missed the treatments, and I turned it into my supervisor, and she looked at me like I was crazy. I said, but I just want you to know that I couldn't get to the treatments.
Right. Large part of that is just honesty, right?
Yes.
Honesty, being real about it.
Yeah.
100%.
Yeah. I mean, we're human. We're not infallible people. We make mistakes.
Yeah.
Yep.
And when you make a mistake, own the mistake. I made a mistake once. I was bagging a patient. We took him from the trauma room to CT to this tiny little X-ray room. We had 7200s. We had a air compressor that you turned on. Then you turn the ventilator on. You put the patient on. Turned on the air compressor. It was busy in this little room. It was loud. Put the patient on the ventilator.
You've only made one mistake. I need a whole.
No, I've made more than one. I'm giving you an example. I'm giving you a good example of about 60 seconds in. The nurse says, "Hey, this patient's starting to desaturate." I looked at the monitor. I looked at the patient. I looked at the vent. I said, "Oh my God, I didn't turn the ventilator on." Took the patient off, bagged him back up, turned the vent on. Honestly, own it. She says, "We're gonna have to tell, we got to go back and tell the ED resident." I'm like, yeah, absolutely. Like, I made a mistake. I'll own it. Absolutely. And the resident was like, "Yeah, it's not going to hurt him." Blah, blah, blah. And whatever. She wrote it up, and I got called into the director's office, and I said, 100% made a mistake, error. She said, he goes, and then, he said, "Yeah, the nurse noted right away that you took care of it, except you were very apologetic." And I said, "Well, I'm human. I make a mistake." The good
outcome. I bet you've never made that mistake again.
I've never made that mistake again. Right. And this is what I teach. I teach my therapists. We had one time we moved a baby on an oscillator, moved the baby. Inadvertently, they forgot to plug back in the battery pack. Right. So what do you think happens 30 minutes later? Yeah. The oscillator shut off. Right. Panic kind of ensues, but everybody's in the room, bagged the baby up, realized what had happened. Therapist called me up to the NICU, and I said, "Okay, did anything bad happen to the baby?" No. This person was here. We bagged the baby. I said, "Okay." I said, "Well, you'll never make that mistake again."
Right.
Well, you make a good point about contrition, which is a value in itself, and learning humility, being able to be humble enough to say, "I made a mistake," and and I think the bad part about that is when they do make a mistake. And they don't know how to own it. You know what I mean? They don't know because they're taught. I think in some cases they're taught that you can't make a mistake. Well, the reality is you're going to make a mistake. I'd never forget. Remember the old dot matrix machine printers that we used to have? So we used to get our printouts like that. And I worked at a small hospital. While I was teaching, I was working on the weekends at a hospital down on the coast. And I printed it out, and I was looking at it. And I went to go get the treatment. Anyway, I ended up giving the wrong medication to the patient. I thought I was going to lose it. I mean, I called the doctor. I said, "Look, I'm really sorry, but here's what happened." And what it was is, and it's just the way that it printed out. It made it look like that medication was for another patient, and it was just weird how it was. So what I had to do was, he was like, "Don't worry about it," because it was still a bronchodilator. It was just the wrong bronchodilator. And so what I had to start doing was taking a Sharpie and drawing a distinct line between each of those patients. So it would give me a visual barrier. But those are the kind of things that we don't just need to teach ethics, but how do you overcome an ethical violation when you whether it's intentional or not? Because if obviously there's a different approach if it's intentional because there's something else going on, but if it's unintentional, you don't want to beat the person up. You just want to help correct them.
Yep. It becomes a learning experience. Yeah,
exactly. And that's the majority of the time we're really trying to do that when we see these things. We're really trying during an investigation. It sounds weird. But we do try to steer them in the right direction. That doesn't mean their case is not going to be adjudicated. What it means is their case is going to be adjudicated, but they see that on the other side there are human beings that see where they're coming from, but here you need to change your behavior. Our recidivism rate is very low because we try to take that step of correction, and sometimes it works. Most of the time it works. Sometimes it doesn't. And unfortunately, people do lose their license. When you give them a chance and they blow the chance and they blow the chance. I mean, there's only so much you can do. We have to be concerned about patients first, just like a practitioner does at the bedside. And for me, that's hard because it's like, how do I prevent something from occurring? I can't. All I can do is after the fact, right? And then prevent things or hopefully prevent things from occurring in the future. Because until something happens, I don't investigate. And, so there's no way I can do that. It's incumbent upon every therapist to do a good assessment of a patient, to look at the patient first, treat the patient first. All the other stuff is just administrative stuff that you have to worry about. But if they're taught that from the beginning, and I always taught my students that, I said, I would always set them up in a lab. And the first thing they'd do, they'd go after the machine, and I'd say, "You failed." And they would go, what did I do wrong? I said, "Well, you didn't look at your patient.
Didn't look at the patient, yeah."
And we would go through that over and over and over again until they got it. It's like they would go to the patient's bed, they would introduce themselves, and then they would move to the ventilator. I said, the only time you may want to touch that ventilator is when things are just going haywire and you need to take the patient off the ventilator to bag them, but don't just go in, silence the alarm and do what you're going to do, because what's going on?
Right.
Why is that alarm going off?
There's a reason.
But it is really, I think it really comes down to being that simple, when it comes to teaching ethics, is that getting to the heart of the matter, which is the patient, and going out from there and building everything around that, because there's a reason they got into this field, and it can't be for the money necessarily. It's got to be for, we make good money by comparison to what we did 30 years ago. Right. I mean, when I first started working, I was making like $6 an hour. If that, I think maybe it's $5.50. So we've come a long way. But you still you cannot get into a profession for just the money. I mean, you can, but those are the ones I would really worry about ethically, more so than those who got in for the right reason. So we always try to bring them back to, well, why did you get into this field?
Yeah.
I think when you reflect that upon them, they start thinking, well, I got in the field because I wanted to help people. So can you help people by doing therapy like this, by mischarting or, falsifying your records? Well, no, I can't. So we get them to start to feel again that, hey, I can make this change. I need to make this change. I want to stay in the field, because that's what it comes down to. There are some people that, they don't want to. And
I think that sums up exactly what we were trying to do on this podcast. Thank you, Bill. I think that was awesome. That was perfect.
We hit every single one of these questions, Bill, and that was
okay.
And you rolled through it, man. It was excellent. Excellent.
Yeah, we only had to ask one, and the rest of them just that was awesome. I do honestly think that there's an in-depth conversation on a couple of these issues. We may ask you to come back, Bill, if that'd be all right for a couple of these. But I think for today, I think we kind of hit the heart of what we were going for. Thank you so much.
Well, I enjoy talking about ethics, and anytime, we'd love to do it.
That's awesome.
Awesome. Thanks. All right, you ready? We're going to close it out for the day.
All right.
Yep. Go ahead and close it out there, Rob.
All right. Thanks, everybody, and join us next time on Let's Get Ethical.